Dr. Brooks trained in medicine and infectious disease at Harvard, served as an EIS officer, and more recently was the incident commander for the CDC's response to Scott County outbreak. So please join me in welcoming Dr. Brooks, who has traveled across the country to speak with us today.
Thanks, Phil. That's great. Thank you. Hi, good morning, everybody. It's about 1 o'clock for me, so my breakfast was my lunch. Well, good morning. It's really great to be here, and thank you very much for allowing me the opportunity to speak to you all. Can you hear me fine if I'm this far from the microphone? Because I have to stand back a bit to be able to see the print on the slides. I'm getting a little older. So I just want to give this, I've got about 45 to 50 minutes to bring you up to speed about what we've learned from the Indiana event. I have no financial affiliations to disclose. And I want to start by kind of going over and setting the stage of where we are, where we have been coming from and where we are now. This is a slide that shows the number of new HIV diagnoses by year for the 10-year period, 2005 to 2014, among the three major risk groups in the United States: men of sex with men, heterosexual contact, and injection drug users. And among people who inject drugs, we've made tremendous progress. More than a 63% decline in that 10-year period, 6% of all new infections in 2014. And consider that in the early 1990s, injection drug use accounted for over 30% of AIDS diagnoses at that time. So this collective public health and clinical success is only surpassed right now, I think, by mother-to-child transmission, the tremendous reduction we've had in that arena as well. But this progress is threatened very seriously right now. And while I don't have the data here to show you, I can tell you from our surveillance data that that 6% has remained flat for the next 3 years. The decline is now stabilizing. What really brought all of our attention to this was the event that Dan mentioned earlier, the outbreak in Scott County, Indiana. And this was a very small county, 24,000 persons, a city of about 4,200 people, where a single strain of HIV spread remarkably rapidly within a dense network of injection drug users or persons who inject drugs using the prescription drug Opana-ER. This is an extended formulation of the drug oxymorphone. To date, there have been 225 total HIV infections, and notably at the time, this was a very challenged community. It rated 92nd among 92 counties in Indiana in terms of life expectancy and other health and social indicators. A lot of unemployment, twice the national average at the time. A fifth of persons were unemployed or had not completed high school education. Many persons were uninsured. Coincidentally, that changed. Seema Varma, the CMS head presently, who was working in Indiana at the time, opened up ACA access a month before this outbreak was identified. So that turned out to be a very beneficial thing. But if you look at the community now, the prevalence in the county, given the population, is about 1%. The prevalence in this city is somewhere akin to 5%. That's an enormous concentration of people living with HIV in a small place. And this is rural America, not where any of us, I think in my job at least 5 years ago, would have thought this is where we have to really worry about HIV. And of course, the cost to this community is enormous. It's going to be at least over $100 million for the lifetime of these persons to keep them treated, safe, and from passing that infection to other people. So this is where a little bit of money spent ahead may have had a lot of benefit if it had been prevented. And it really is a lesson that we want to prevent this from happening again. I just want to illustrate for you some of the principles of the investigation that took place, because I think particularly for an audience where there may be clinicians in the room, it's fascinating the parallel between how we treat a disease in an individual and how we respond to a community as a public health agency. You know, when you have a condition like let's say you've got tuberculosis or you have some form of cancer, the first thing you need to do is detect the problem is present. And we made this diagnosis, if you will, over the course of a couple of weeks in the end of 2014, early 2015. It took time to confirm that there was a cluster of genetically related infections, and once that took place, we really led with induction. We went out and attacked this as best we could with a very large number of resources. The state actually activated its emergency response network, the emergency command. This is what they would normally have used for a tornado, an earthquake, or some terrorist event. It was the first time it had actually been used for an infectious disease problem. And then we did a number of other things that we wanted to try and make sure we were containing the problem. Testing in jails of surrounding counties, looking for other people who were at high risk of acquisition of HIV through injection drug use to see if the problem was geographically isolated to the county. We had teams of disease intervention specialists, about 30 people from around the country, who went door to door in this community, seeking out individuals, asking them, we'd like to test you, following up with those who had tested positive to find their contacts and begin to delineate what the network was like. They collected both, they were trained to collect both venous specimens and do point-of-care testing for HIV. And then they were directed to services according to the various issues. If they were infected, then they were directed to HIV treatment services, and if they weren't, we directed them to prevention services. Then after the number of cases began to fall, we really focused on a consolidation phase like you do in cancer or tuberculosis, you come off the hard therapy, now you get to a point of just trying to get everybody diagnosed and everybody into the system of care that you want. And eventually, you can begin to pull back a little bit on those resources. Of course, many of them need to stay in some form because they're critical for preventing this from flaring up again. But then you sequentially retest as many people as you can in the community, so you go back and keep scanning for disease to see if it's continuing and to make sure that it's not flaring up again. Interestingly, that has consistently been detecting a few infections every couple of months, and I'll show you what it looks like in the most recent slide towards the end. The most recent data I've gotten a slide towards the end, but not unexpectedly. Many of the people that we have followed up and found to be infected with HIV in this case were persons who declined testing. You know, it's a condition, as Dan alluded to, I think we all recognize is highly stigmatizing. When the government comes knocking on your door and we want to talk to you, not everybody's going to respond openly and say, yes, please come in and get to know me. Many of these people, though, as trust grew in the community, began to seek out testing and care, but not everybody did. And we've definitely had people who, despite the fact that they had been tested at least once and engaged in prevention services, have gone on to develop HIV infection. I want to talk a little bit about the drug that was involved in this outbreak because I think there were unique characteristics of this drug that fueled the rapid spread of infection. Opana-ER is a form of oxymorphone that contains a crush deterrent. It's got a chemical in it that makes it very hard to crush it into a powder, which is the way people preferred using oxymorphone before it had the deterrent. They like to crush it up and snort it. But what you have to do now if you want to prepare it is you have to dissolve it in a little bit of liquid. You get a jelly-like substance, and then you got to dilute that in a lot of water and then inject that. So moving from what opioids do down to what Opana-ER added, you know, opioids have a tremendous addiction potential, as we're all aware, and their duration can be very short, a number of hours, so you have to use more frequently. When we were interviewing people about their experience with oxymorphone, they were telling us that they were experiencing more intense withdrawal, which they attributed to the greater potency of the drug. I think a lot of addiction specialists may question whether that's a true effect or not, but this was the experience at least people related to us. More importantly, though, it was the crush deterrent in the drug that was playing a really big role here. First, people who had previously been crushing a pill that they could snort told us, frankly, I wanted that drug, and I moved to injection because I could no longer crush it into a powder. Secondly, the jelly-like substance that you got when you melted it or dissolved it in water not only created a greater solvent need, you needed more water to inject so that you had to pull up 2 or maybe 3 syringefuls to get the full dose in. Dan showed the 1 mil, right? This would take up to 2 mils in some cases to get the full amount of liquid in. You know, you're not going to just do 1 and waste the rest of it. Also, this was not a very pure substance, and when they dissolved it with heat, it left a brown residue in the cooker. And this was a visual clue to the users in the community that, oh, there could be something left. So they'd go back, rinse it up, and pull up a 3rd shot. So they were putting a needle, each time they were using drugs, they were putting a needle into their arm 2, 3, 4, 5 times. And then, of course, the higher cost of the drug led people, and the absence of needles in the community at the time really led people to have to start sharing drug, and while sharing drug, they often shared injection equipment. So this really fueled the addiction potential, the misuse potential and the transmission of HIV, the risk. And as a result of these events, the FDA has since asked for the drug, and it's successfully been pulled from the market because of its public health threat. It didn't add a whole lot, but it posed a lot of threat. So why did this event happen? As epidemiologists, we always want to know what has changed. You all are probably familiar with this cover of Time. This is a few months after the outbreak in Indiana, showing that we've got an opioid problem in America. Dan showed this really fascinating analysis that as motor vehicle accidents have been going down, deaths from overdose have been going up behind our back, you know, in many ways. Not everybody was aware of this. 2010 was the crossover year. And consistently, opioids have had a larger and larger role in the cause of those overdoses. Some people said, well, it's just overdose. Overdose from what? Well, 30% moving up to about 60% in 2010, and this crossover in 2010 of deaths due to overdose exceeding motor vehicle accidents has continued into the future. As drug use, in particular opioid abuse, increases, so too do the number of people who are injecting. I can't necessarily, maybe Dan could help me, predict among users who's going to move into injecting, but a predictable fraction of people will move into injection. So if you have a population of people that are misusing drugs and that's increasing, more and more people are going to be injecting. So we were very concerned about this trend, and we wanted to know, well, where in the United States could an event like that in Scott County happen again? As a prevention agency, we want to be able to warn people that we've seen this sentinel event in a county in Indiana. Where else do people need to be on alert for the same thing happening? Ideally, we could say, well, where are people injecting drugs unsafely? Stigmatized, criminalized behavior, we don't have a good surveillance system to know very well where people are doing that. But we do have a marker of people who have recently injected drugs in a problematic way, a way that could transmit infection, and that is the presence of acute hepatitis C. Acute hepatitis C can act as footprints for us because it not only is highly transmissible through injection drug use, particularly non-sterile injection drug use, but the acute phase of the infection is short-lived. So that if the person is diagnosed with acute hepatitis C, I know that the event that infected them must have occurred within the last few months to a year. I just contrast that with HIV, where when we make a diagnosis of HIV, until recently, it was hard for us to know how long ago that event occurred, and that's always been an issue in HIV epidemiology. So if a person, in places where acute hep C is occurring, we hypothesize that that must be a place where there's a problematic injection drug use occurring. And really the rapid expansion of the opioid epidemic and increasing injection drug use was heralded by an epidemic of hepatitis C infections that was occurring at the same time and preceded the events in Indiana, but hadn't been getting the attention that it may have now in retrospect deserved. Shown here is an analysis from a colleague of mine in our Division of Viral Hepatitis looking at the rates of acute hepatitis C by country in the eastern half of the United States. And the darker the red, the higher the rate of acute hepatitis C in that county for that year. And I think you can see that for 2006, moving into 2012, it's a lot redder. And in fact, if you look at just Indiana, really none of the counties stood out in Indiana, but by 2016, they were having a problem with acute hep C. And Scott County is among the little counties up there, by the way. It's a very small little county. It goes on tight. This phenomenon is, interestingly, not solely an urban problem. We know that acute hepatitis C is going up nationwide, but the rate at which it is going up in non-urban settings is faster than that in urban settings. So the rate is higher. The light blue bars are non-urban settings. The dark blue bars are urban settings. It's not only higher rate each year, but the pace at which it's increasing is greater as well. Other important changes that we've garnered from surveillance data, looking at people infected with hepatitis C and acute HIV that are injection drug users. The focus is changing. It's no longer solely an urban phenomenon, but it's also now an increasing non-urban phenomenon. Whereas we used to worry about people who inject drugs as being mostly the baby boomer generation, increasingly it's young people, people in their 20s up until around age 40. Race ethnicity has traditionally been an issue of Black and Hispanic Latino Americans, but increasingly white Americans are involved as well. And interestingly, the male to female ratio is changing. It used to be a condition that affected males more so than females, but now it's an equal opportunity problem. Unless you think that hepatitis C is a benign infection, I just want to remind folks that in our surveillance data, looking at the causes of death among all the infectious diseases reported to CDC, in around 2012, death from hepatitis C, where the death was attributed to a complication of hepatitis C, cancer, end-stage liver disease, something like that, deaths from that individual infection surpassed all deaths due to all other 60 infectious diseases that are reported, including HIV. And we now believe that non-sterile injection is the leading cause of new hepatitis C infections. New infections in 2015, 33,000, 34,000 roughly. And we estimate that today about 334,000 persons living with hepatitis C infection are persons who inject drugs, or somewhere around 40% of the community of people who inject drugs in the US. So to try and really this is an important problem, and to try and hone in on where it could be occurring and to warn communities, we undertook a exercise to try and find where are places that are vulnerable to an event like that which occurred in Scott County, Indiana. And to do that, we used a multi-stage approach. And before I go into this, let me just ask, is there anybody here not familiar with the Framingham score? It's okay to raise your hand if you don't know. It's okay. Yeah, okay, good. So the Framingham score is something we use with individual patients. And it was derived by asking the question, if I'm looking for an outcome of cardiovascular event in 10 years, what is the set of predictors from an individual that I could take to best predict that person's risk? So they determined that looking at the person's age, their sex, whether their cholesterol, their smoking history, if I know the person's individual responses to those questions, I can give them a numeric prediction of their vulnerability to a cardiovascular event. We attempted to do the same thing, but looking at the county level. So we wanted to find what was the parsimonious set of variables that best predicted problematic injection drug use, again defined as diagnosis of acute hepatitis C, and then use that to score individual counties to rank them according to vulnerability. We did this using a Poisson regression model. I'm very grateful for the statisticians at our agency who can do this, because I'm not that great. But we got together a group of subject matter experts, put all these ideas out on a table of what are things that might predict problematic injection drug use. They had to be plausibly or known associated, and we also required they be national level, and that's a limitation I'll mention later why that was important. We wanted it to be recent. I don't want data from 1990. I want data from now, because that's what's going to make the biggest difference. And we wanted it to be complete. We wanted it to be a variable that any community was likely to have available to them if they wanted to work on this. And then, as I mentioned before, we used as our outcome how well did these variables predict the amount of acute hepatitis C in a county. The most parsimonious set of 6 variables in the end that consistently and best predicted this are shown here. And I think it's not very surprising that given the circumstances at the time that this was happening, percent white population ended up being a strong predictor. Drug overdose death, not surprising. Per capita income, the lower, the worse. Percent unemployment, sort of a different side of that coin. The prescription opioid sales, the amount of drug that were available in the community. And then lastly, buprenorphine prescribing capacity. Buprenorphine, as I'm sure many of you know, is a drug used in what's alternately called opioid substitution or medication-assisted therapy, where like like methadone, we help people overcome the need to put a needle in their arm so they can get a drug that stops the withdrawal and the drug sickness they may experience. And here, buprenorphine prescribing potential were data we could gather from SAMHSA, Substance Abuse and Mental Health Services Administration, which is an agency that waivers providers to provide buprenorphine. You can get it's not that hard, it takes some time, but you can get a certificate that you've been trained to administer this drug. And we asked, well, how many people in each county have been waivered to do this? And we figure that that represented the demand for addiction services in a community, and it turned out, I think, that we were right. So then we took these 6 variables, and for each county, we took its score on that variable, weighted them according to their contribution, and added them up to get a ranked score of the top roughly 5% of counties, the most vulnerable counties among the 3,143 counties in 2015 at that time. This is the map, this is the money slide that kind of shows what we found. And I think it's not surprising, as you might expect, that the greatest density of the most vulnerable counties were in the Appalachian region. But interestingly, there were also a concentration in the upper part of Michigan's lower peninsula, parts of New England, particularly northern New England in the Vermont, New Hampshire, and Maine, in the area around Missouri, in the Ozarks, and then also sporadic counties in California. I'll just note, it's interesting that in California, regionally, and this is an important lesson from this exercise, regionally, these are counties in the northern part of the state that are adjacent or near Humboldt County, where some of you may well be aware there's a problem been recently reported not only with a large amount of injection drug use, but possibly also increases in HIV infection. And the lesson we were trying to get people to learn from this exercise was, this is not the most precise method to identify the at-risk counties, but we think that we're probably spot on in regard to the regional areas where there's a problem. So we ask folks to go back and look at their own data and do their own analysis to look better more locally as to what could be going on, and I'll come back to that in a moment, but I just want to remind folks why it's urgent to pay attention to this problem. And that is because we know from historical data that once a bloodborne pathogen enters a population of injection drug users, it spreads remarkably quickly. These are studies of entire cities, 10 cities around the country, that showed that within 1 to 2 years, over 40% of users in these communities, when HIV entered them, they were then infected. And in Scott County, we saw something very similar. But there's a lot we can do to prevent these kinds of problems from occurring. Of course, our most potent intervention right now is treatment for HIV infection. These folks in Scott County and persons who inject drugs are predominantly at risk as a result of their injecting behavior, but they also are at risk for sexual transmission. We don't have good data on how treatment affects the risk of transmission through non-sterile injection, but we have some excellent data, very reassuring data, how these drugs work to prevent sexual transmission. 3 studies, notable for the fact that they're different designs with different populations, looking both at men and women who have sex together as well as men who have sex with men, showing that despite lots of exposure where in a mixed status couple, the HIV-infected partner is suppressed or has an undetectable viral load, and the uninfected partner is being exposed to that person through sexual contact, no genetically linked infections were observed. Now, there were infections observed, but those were not genetically linked. They were infections from somebody outside the partnership. And in the last 2 studies shown here, partner and opposites attract, they actually were able to kind of give us a sense of the amount of exposure. They had over 75,000 condomless acts of vaginal and anal intercourse and over 1,500 couple years of exposure. That's a lot of sex. I'm never going to reach that, but you know, there were no transmissions. Now, I can't tell you right now that absolutely there's no risk, and I would never say that, frankly, as an epidemiologist, because, you know, a meteor could strike us all dead in 1 minute, and I doubt that's going to happen, but I could probably give you a numeric estimate if I was forced to. But I think it's a pretty rare event, and we're going to be seeing more data soon, particularly among MSM, among a different version of the partner study called Partner 2, which is undergoing now, and I think they've completed enrollment, so we should have some data in a couple of years. One of the other things about these studies, just for your 2 things I want to say for your all's awareness, we know from other studies that among men who have suppressed viral loads, they're not shooting blanks in their semen all the time. In up to 8 to 10%, we can sometimes detect the presence of HIV RNA, albeit usually very low levels, but we don't know what that means. In these studies, unfortunately, they either didn't collect semen or they've collected the semen and haven't been able to find somebody to analyze it for them. So we could get a sense of what fraction of these men were not shooting blanks, but transmissions never occurred. That would be a really nice, you know, piece of information to get. We hope to get it with partners too. We also know that although we can't translate this to injection drug users, our agency's estimated per act transmission risk of HIV for receptive anal intercourse is on par with that for injection drug use. I don't want to stretch the analogy, stretch the generalization too far, but, you know, if these things are on par with each other in terms of per act risk, there's going to be a lot of prevention benefit from treatment. We just can't pin it down to a definitive number for injection drug users yet. Other things that work well, you all are very familiar, I hope, with opioid substitution therapy. Meta-analyses have shown you can get a 64% reduction in HIV risk, and needle and syringe programs, what we're now calling syringe service programs. I'm sure in the next few years there'll be another acronym. They can reduce the rate by 56%. Neither of these is perfect alone, but together you get a lot of bang for your buck. Now, these studies have looked at HIV, but we worry also about hepatitis C, but it's a little dicier because hepatitis C is considerably more infectious. So sometimes it's, you know, people haven't seen an effect when they look for how well a syringe service program or medication-assisted therapy can decrease hepatitis C infection. But the Cochrane analysis group in England did some nice meta-analyses where these 2 interventions have been combined, and they found something very interesting, that in places where MAT was widely available and being administered, but that the amount of the pressure, the access to syringe services was present but ranked low in their analysis, they defined it some way, you get a 24% reduction in hep C. But if you were doing the same thing in an area with a high amount of syringe service program action, you got down to 71%. So combining these and getting the most you can out of each can really increase the reach. Sorry, I'm having trouble seeing my slides, so I may not be advancing in a way that's perfect. All right. We also know that when you're opening a syringe service program, restrictive policies, and this is important for policymakers, actually increase the risk for infection. Classic policies that you'll see are that we're happy to have a syringe service program, but we're only going to give you 7 syringes a week, so there's a limit on the weekly thing. Or there's the one-to-one exchange, a very appealing idea to people who find this, who get a little dyspeptic when talking about syringe service programs. Well, at least I can account that each one going out, I'm getting one back, so I feel good about that. And then people who don't make allowance for emergencies. Maybe the syringe service program was closed the day you came to get your syringes filled, or maybe you're going to use more than you need so you can get a couple extra. So you either limit the number per week, you require one-to-one, and you don't provide a few extra for emergencies. And the fewer of these restrictions, the greater the impact of the syringe service program at reducing the risk for HIV. And this is demonstrated very nicely in Vancouver with the cohort Dan talked about, where when the program originally began, there were limits on syringe borrowing, there was a one-to-one limit on the syringe distribution. And when they rescinded that, not only did the amount of syringe borrowing by self-report go down, but so did the amount of syringe lending. So basically, if you are more liberal with your syringe service program, you have a much greater reach, reaching people who may be so stigmatized that they're afraid to come forward, or they don't know about the service, or they're so strung out and their life is so disorganized, somebody can help them by bringing them the syringes and then get them entrained into the system, hopefully. So jumping back to the analysis we did about vulnerability, what did most of these communities have in common? And that is that they were predominantly rural counties in America. And these communities have some important challenges that we need to think about because these are problems that are not going away anytime soon. First is that they have very limited access to services. They don't have the privilege of living in Atlanta or San Francisco where they can take public transportation to go someplace if they can get their act together. There are long distances between these places. In Indiana, there was at the time of the outbreak, they had 15 methadone programs. The nearest one to Scott County was 45 minutes away. And most people don't have transportation options. We're used to the idea that people in rural America have cars, but in Scott County, Indiana, many people had sold their cars to pay for drugs, and they walked everywhere in the community. And Greyhound doesn't reach every community anymore in America. When I was growing up, it was really common to take buses between cities, and you don't find that anymore. And of course, they were uninsured. That changed, as I mentioned, but prior to that, if they had wanted to seek care, that was a barrier because they were afraid of the cost that they were going to be left with if they had a terrible diagnosis like endocarditis. There's also, and alluded to earlier here, long-standing distrust between the community of persons in public health who work with persons who inject drugs and the community of public safety folks who work with law enforcement and community leaders. That we're kind of at different odds. The public health community wants to reach out and bring folks in and give them safe, clean material to inject. The law enforcement community has been in a war on drugs for many years. And there's been a growing dialogue, and I think Dan mentioned that with interdiction, and particularly with fentanyl, there's been some tension here, but there has been, at least until recently, a growing dialogue where the public safety and public health community are working together to address the thing that they both share, which is taking care of the public. And in North Carolina, there's a really nice example of how these communities are working, where they get folks from the community to come and meet with the law enforcement officials, and then the law enforcement folks and the harm reduction folks have created documents that they can give to law officers, EMTs, to help them understand the value of preventing these infections by access to syringe service programs. So now I have to turn here so I can read it. But it talks about how much money, there you go, how much it costs to take care of these infections and how much you can save if you prevent it with the syringe service program. That these programs also pick up the dirty needles. When you're moving 1 million needles a year through a community, that's a lot of sharps that could end out on the street. but an important tenet of a syringe service program is to provide a place to dispose of those. And contrary to expectation, crime decreases in these communities, and it doesn't just have to come from public funds. A lot of private places are happy to contribute. And of course, that these places, like a syringe service program that's meeting a user every day at they still have to come to you, so you're not perfectly meeting them where they are, but you're having an ongoing relationship. And you're there so that when they decide, or if they decide they want to pursue addiction treatment, HIV testing, if they want to learn how to prevent an overdose and get drugs to do that, that's a venue, that's a place, a nexus where this can occur. And then lastly, the thing that probably sells it most to law enforcement is that, when this has been studied, that the number of needle sticks law enforcement experience goes down substantially when you have a syringe service program in your community. Lastly, and not surprisingly, I suppose, is the problem of limited infrastructure. In Scott County, testing for HIV and hepatitis C were available, but it wasn't easy to get to. There had been a community-based provider who had been defunded and was no longer able to offer the tests. And if you wanted to get an HIV test, you had to go to the you had to go to the county health department, which was adjacent to the police department. So you can imagine people engaging in a criminal behavior really aren't all feeling so hot and bothered to run to the public health department when the cop who's ready to arrest them is right next door if they have a needle on them. Services for HIV and hepatitis C are not very widely available. People with HIV in this community before the outbreak was identified traveled either to Indianapolis, about an hour north, or to Louisville, about an hour south. So that's a challenge with transportation, and you're using drugs where you need to inject, in a shorter period than that. You don't want to get onto America's highways and possibly get pulled over by someone and have a needle or drugs on you. In this community, there was a physician who stood up and said, I'm a family practice doctor, this is my mission, I want to treat these people. And he has done a remarkable, remarkable job learning about HIV, proving that anybody now who's clinically trained can be a primary HIV provider, and doing a great job ministering to this community. He's a terrific guy. Medication-assisted therapy, as I mentioned, didn't exist in the community. It wasn't proximal or easy to get to, and syringe service programs were illegal in Indiana at the time the outbreak occurred. So you have to always be concerned when you want to introduce these, whether the policy environment is fertile for this idea. Well, that changed during this outbreak. As a result of that outbreak, our current vice president, governor of Indiana at the time, was compelled, within a month of learning of this condition, to change his opinion about, at least publicly, about syringe service programs and allow an emergency syringe service program to be started in this county. And for those of you who are as old as I, or who are not as old as I and don't remember, Mr. Pence was, while he was a congressman, was one of the most outspoken anti-SSP people in the American sphere. So I think if an event like this, and you can talk to people about the human side of this story, can compel someone like this to change his mind, there's a lot of hope. The other guy in this picture, by the way, is the state health officer in Indiana at the time, who's now our Surgeon General, Jerome Adams. This emergency declaration was declared again for one more month, and then in the next month, the state took up a bill and made the program of syringe service programs as a part of an emergency response, something that could be permitted statewide. And to date, I believe there are 8 or 9 syringe service programs now beginning or operating in Indiana. I want to remind people that it's not enough, however, just to get the program started. You have had some policymakers, depending on where you live, make some really difficult decisions where they're going to face a lot of pushback potentially from some of their constituents. And giving them the data that shows it's working is important. So in this outbreak, as quickly as we could, we provided data that showed that the syringe service program was changing behaviors. We took people who had been engaged in the program for at least, on average rather, 10 weeks, and compared how often they reported either sharing equipment or using equipment to share division of drugs or to inject drugs together, both at the day they started in the syringe service program and about 10 weeks later. And it went down very, very significantly in all 3 of those measures. You might ask yourself, well, why was it so low to begin with? You told me these people had no access to syringes and whatnot, right? But already only 20% are saying they're doing this. That's because by the time we got the study started, the syringe program had been underway, and people by this point were very well aware that there was a problem in their community, and that if you were a person who injects drugs, you could be a sitting duck for one of these problems, and they were seeking out safe injection equipment. And this helped make it possible that everybody could be protected. So in Scott County today, we've been looking at 3 variables to kind of measure our progress. These blue bars are the number of people who, through the syringe service program, have had an initial contact with some form of addiction treatment, medication-assisted therapy, referral for mental health services, alcohol addiction, but that was the point of contact where they reached out onto the road to recovery, and that's been steadily going up. At the same time, shown in the green line, the demand for syringes has remained stable. The number of syringes, I think we measured it, average number of syringes per client by week, by quarter, rock stable. It's not that the number of people requiring syringes has changed, that's probably gone down some, but that the number of syringes those using require has remained stable. And this important argument against the hypothesis often raised that syringe service programs simply increase drug usage. If that were occurring, we'd probably see more syringes used per person if they kept using that drug. But I'll show you next something about that too. And then lastly, in red, the number of HIV infections has gone down substantially. And knocking on wood, we haven't had an infection in a couple of months now. So this has done, we think, a good job at trying to control spread of HIV in this community. I want to show you this map that then overlays nationally. In pink now, the counties that we assessed as being highly vulnerable, with the presence, measured as green dots, of syringe service programs in the country at the time. And I hope that if you just look at it for a couple of minutes, there's like no overlap whatsoever between these 2 variables. I mean, I don't think there's one place where they're overlapping. And that's an important story, I think. I think it's telling us a couple of potential things. First, that there was something about, there are a couple of explanations for what's going on. Let me back up and put this a different way. There are a couple of explanations for what may have been going on. Why weren't the urban areas showing up as being vulnerable? And one hypothesis that's been raised is that when you take, remember we were using acute hepatitis C infections as our denominator, and our numerator was the population in that area. And maybe in huge population areas like, you know, the Bay Area, New York City, Baltimore, Boston, that large denominator diluted the number of acute hepatitis C infections, so they didn't appear to have a high rate. You know, we're always looking at rates. Possible, but I don't think that's the case. And look at New Mexico, a predominantly rural place where there are lots of syringe service programs, but there wasn't any place that came up as vulnerable. In fact, I think what this probably shows is that syringe service programs protected those communities from appearing to be vulnerable because we weren't seeing a lot of acute hepatitis C there. And there's 2 explanations for that, unfortunately. It's either that they were protected or we'd saturated the market. That is, most of the people who were going to get hep C already had it. But it did mean they weren't vulnerable, and that this was not going to be quite as explosive in other places. And this information has been put into action by a number of states. This is an example from Kentucky, comparing the distribution of syringe service programs in 2016 to 18, and it's ramped up from 15 to 54. In the early part of 2015, the state made syringe service programs legal, and then the public health department worked aggressively to begin initiating SSPs in various parts of the state, which they also recognized were very vulnerable to this. Recall that I said our analysis had some limitations. We required to be national data, very complete, and very recent. And that meant that there was a lot of potentially informative pieces of information that we didn't consider. So again, our look was probably very general. There were things that we would really like to have looked at, like not only what was the overdose rate, but what were the overdose rates by drug. I'd like to look specifically at opioid overdoses. How many calls to a poison control center? Maybe that's a measure that there's something going on in a community. Arrests for drug possession, naloxone administration, or other drug-related crimes. So information from the public safety sector. And then from the healthcare sector, I mean, how many people are being treated for an overdose would have been a great variable to have our handle on, but it's not available nationally. The number of people presenting to ERs or who are making EMS calls for overdose. Medical toxicology reports, so we could know among people who overdosed what was the drug. And then, as Dan mentioned earlier, bacterial infections related to injection drug use. A lot of communities, a lot, and I'd be interested to know what's happening here too, have seen endocarditis rates and deep abscess rates really going up dramatically. And in some parts of our country today, there's a very active debate around whether somebody who's coming in for their third valve infection, they've had the native valve infected once and replaced, the replacement gets infected and they've replaced that one. What are we going to do with that third person? And I don't have an answer for you, but this is the kind of debate that we're going to be coming up to. And then lastly, access to substance use disorder services, admissions to rehab centers or for medication-assisted therapy, variables we didn't have, but which we believe, as all of these I believe are, some of them can be found at the state level. And when you go out and get this information, there's another magic thing that happens for the health department. The health department has to learn who their friends and partners are in law enforcement, in the pharmacy board, in the medical examiner's office. They start to begin to build partnerships and relationships with non-traditional folks that they've not worked with before, and that really advances public health for us and our mission of making sure everybody's covered. This is an example of Tennessee's own local vulnerability analysis. We recommended that all states consider doing something like this. Tennessee went back and said, we'll do what CDC's done, we'll get the data from the health department, collaborate with Vanderbilt University, but we're also going to use local variables. We're going to bring in what we know about overdoses due to heroin, the amount of morphine mill equivalents being prescribed, and kind of put this data together to get a more local picture. In that exercise, they met all these new partners they hadn't worked with before, and they're better prepared to respond if an emergency comes along. Secondly, they had data about Tennessee. And when you go to speak to the Tennessee legislature, they like to hear about their own state. A lot of people don't really trust the federal government. I don't know why. But, when local people can talk about their local problem, that can often get a lot more traction. And they found that this has been very persuasive at moving resources. And I will note that although it's different, they're not comparable. The same general dark areas are in the same place. It's just that they have a much better fix on their own problem now using more recent data. I wanted to close talking a little bit about the laboratory investigation for those of you in the room who are interested in this kind of thing. As I mentioned, this was an outbreak of infection spread by a single strain of HIV, had 99.7% identity across the 1,302 base pairs that we compared. Luckily, no antiretroviral drug resistance. All infections could be epidemiologically linked in space to Scott County. We had the availability of near real-time poll sequencing that we could feed back to the people in the field and say, that person you diagnosed 3 days ago, they're part of the outbreak. That person, not part of the outbreak. And that was very helpful for us to also define the geography. And then we used recency testing to determine how many of the infections had occurred in the last 200 to 300 days. And that helped us know what it looked like in terms of span of time. Was this a rapidly evolving outbreak where infections were occurring like this, or were we just diagnosing a whole bunch of people who have had HIV for many years but weren't being diagnosed previously? And that was not the case. Most of the infections, the vast majority, were persons who had just recently been infected. Well, we wanted to really better understand, for a variety of reasons, how the infection spread. So to do this, we undertook a number of higher-level analyses that my colleagues in surveillance and our laboratory conducted. First was this basic network analysis based only on epidata, asking, how are people related by either injection drug use behavior, sex together, or both of those. And the larger the circle, the more number of contacts that person had, and if it's red, that person has HIV, if it's blue, they don't. And the lesson here is that although there's a very large, very dense network, it was really driven by a core of about 10 people who had lots and lots and lots of contacts. How quickly did these infections spread? In the red line is the projected epi curve, the number of new infections over the time that we were doing the outbreak investigation. The blue curve shows the estimated actual dates of infection based on the recency testing and some other laboratory data that we have. And if you look at the close-up on the right, by the time the investigation began in late January, early part of February, over 100 people were already infected. We were catching up, making these diagnoses. Eventually, we saturated and we reached the point where we think we began cutting off new infections. But the lesson here is that the first infection related to the outbreak goes all the way back to 2011. And things went along very quietly for some time, and then there was this explosive growth that luckily was detected early and we were able to cut off after a few months. So what exactly happened here with these 150 people? Well, when you do the genetic analyses we did in the ones you do in general to look for clustering, you allow 1.5% difference between strains. So if when you compare them, they're at least within 1.5% of each other in terms of variation, we would say those are clustered together. But what if you become much more restrictive and allow a much tighter variable, a much tighter interval? Let's say that we, instead of allowing 1.5%, we say that even a 0.1% difference, a single nucleotide substitution, is enough to define you as being different from you. And when you do that, you can see that these infections, the individual infections, begin to cluster into little groups together, which were defined here with letters of the alphabet. And you can then take these data and add to it some computational work that constructs minimal spanning trees between these groups to try and say how do they cluster as little balls together and relate to one another. It's one of these iterative computer programs, there are a lot of them out there right now, that runs for overnight, maybe 2 days, and then gives you sort of the best fit of how these groups are put together. And then on top of that, we have a program that allows us to weave in the epidemiologic data. What do we know about the recency, the order in which people became infected, and the ways in which they were related? And we think in the end, this gave us an informative story to tell about what may have happened here that's instructive for other locations as well. This person right here is the first diagnosis in 2011. And this person clustered with a group of people here, which included 3 commercial sex workers who worked at a truck stop. That was a popular venue for sex trade in the area. And then each of these were related to different subgroups. And although when we interviewed these people, this person in particular denied any sexual contact with any of these folks, these people said, well, no, I did have sexual contact with this person. The reason the line is not solid is because we can't confirm it from both perspectives. But what this seems to show is that there may have been an infection sitting around for a long time in the community. Then when the conditions were ripe and it could be moved into injection drug use community, it spread like wildfire. So the importance is that you do need to be aware and careful about preventing transmission through injection drug use, but sex can also be the match that lights the fire. So just in conclusion, we're in the midst of a bad opioid outbreak, beginning perhaps with prescription opioids, moving to heroin, now synthetic opioids like fentanyl or the rising star. It's generating a whole new population of people, enormous population potentially, of people injecting drugs that we did not previously consider vulnerable to hepatitis and HIV, and that could spread this infection very rapidly through injection drug use. They are predominantly rural, but not exclusively, and I think we're beginning to see more signals that this is becoming an urban problem as well. And I do want to just point out that this threatens to erode our substantial collective success that I mentioned before with PWID. And being able to rapidly detect clusters and characterize how they relate, as I showed before, is going to be very important for us, I think, in moving forward. We're beginning to see, and I made this footnote here, Dan alluded to the problem in Massachusetts. We've also seen HIV clusters related to either sex or mostly injection drug use in Texas now, Ohio and Kentucky, West Virginia, and possibly soon Humboldt County. I hope not. And evidence-based interventions to reduce the infection risk of non-sterile injection leading to infection is an important thing for us. Models to operationalize this in rural settings are very limited right now, but are growing. And I firmly believe, as coming from my agency, that if we stand behind the best available science, this will guide us in helping policymakers make the correct decisions. I do want to just point out that these are the agencies involved in responding to the outbreak in Indiana. It is really a cast of hundreds and hundreds of people. So if for no other reason we need to prevent this from sucking up all of these resources for so much time to address a big problem. And each of these individuals across all of these agencies made enormous individual contributions that prevented the outbreak from spreading further. So thank you very much for your time. I'd be happy to answer any questions.